Thanks, Claire, and good evening, everybody. Last Thursday, my nieces headed off to school, dressed head to toe in hideous polyester onesies. What made them forsake their Uggs and their Abercrombie? Well, it was World Diabetes Day, and they were part of a global movement to raise funds for diabetes research on Type Onesie Day, as they called it. We hear frequently that diabetes is a major health problem, and we all know that it's associated with the epidemic of obesity. Sometimes it can feel like yet another guilt trip loaded onto the developed world. But where do you think has the highest incidence of diabetes? The US? Actually, very recent figures tell us that 112 million people, or 12% of adults in China, have diabetes. In India, the figure is about 50 million. In the US, it's about 30 million, or 11% of the adult population. The figures in Egypt are around 26%. Numbers are expected to double in the next 20 years, predominantly in Asia and Africa. So you get the picture, diabetes is a global epidemic. But what's the big deal? Isn't this just a disease that we can manage by taking insulin and taking it easy at dessert time? Actually, that really isn't the case. It's pretty complicated. People with diabetes are at a much higher risk of heart disease and stroke, and diabetes is the leading cause of blindness, kidney failure, and limb amputation. Almost half of the patients who are on dialysis have diabetic kidney disease, and current therapies are of limited impact. At best, they may slow disease progression, but they don't stop or reverse it. So, given this scenario, you can imagine that the impact of managing the chronic complications of diabetes is enormous. In Ireland, about 7% of total healthcare spend is on diabetes and related complications. In the US, this figure is more like 10%. And in fact, last year, a study in Britain concluded that the costs associated with diabetes would bankrupt the NHS within 20 years. Clearly, the impact on developing economies will be even greater. So, what goes wrong in diabetes? Well, to function, all cells need energy. And in health, our cells take in glucose from blood and break it down to produce this energy. In the healthy condition, the levels of blood glucose are kept within a very narrow range, whether a person is running a marathon, lying on the couch, eating chocolate, or hopefully scoring tries against the All Blacks next weekend. When levels of glucose go up in the bloodstream, the body senses this and it produces a hormone called insulin. And what insulin does is it's essential to get glucose out of the bloodstream and into the cells where it can produce energy. So just imagine what happens if the system goes awry. So if either the production of insulin or the response of the target cells to insulin is compromised, in these circumstances, glucose can't get into the cells. And as levels of glucose in the blood rise, various organs get coated in this sticky mess. And this underlies the development of catastrophic chronic complications of diabetes, such as, for example, blindness and kidney failure, which certain people are susceptible to. But what we must remember is diabetes is nothing new. It's been described since antiquity. In fact, the standard diagnostic test in India, almost 3,000 years ago, involved seeing if ants were attracted to urine, a sure sign of the presence of unabsorbed glucose, or sweet pea. In type 1 diabetes, the cells that produce insulin in the pancreas are destroyed. And in the early 20th century, the discovery of insulin and its subsequent commercial production turned type 1 diabetes from a fatal disease into a chronic treatable condition. But of course, insulin isn't a cure for diabetes, it's merely a treatment. However, the majority of people with diabetes have an alternative form of the disease, type 2 diabetes, and this is the one that is very frequently associated with obesity. In this type of diabetes, the target cells are relatively unresponsive to insulin. Insulin is basically knocking on the door of the cells to let glucose in, but the cell is not responding, and eventually the cells of the pancreas stop producing insulin as well. So, I'm a scientist, and what really drives me is curiosity. Why and how? Why does obesity drive type 2 diabetes? Why does diabetes drive kidney disease? And if we can understand the details of how, maybe we can think of effective interventions. So over the past decade, research on type 2 diabetes and obesity has pointed to a role for inflammation. Now, typically we think of inflammation as the process through which, for example, white blood cells defend our body by being recruited to specific sites of infection. So these are essentially defensive cells. In obesity, it turns out that the fat that coats the organs in our abdomen isn't just the inert lardy stuff that we may find elsewhere in our body, but this visceral fat is actually an active organ in a state of low-grade inflammation containing destructive white blood cells which provoke insulin resistance in this fat tissue and, as a consequence, the development of type 2 diabetes. You may be familiar with the idea of the apple and the pear body type. Well, actually, this designation of the apple shape is associated with an increased risk of type 2 diabetes, because what that reflects is this increased intra-abdominal fat, or this visceral fat that's in fact an inflamed organ, this chronic low-grade inflammation that has a very important role in driving type 2 diabetes. So I've explained to you that in type 2 diabetes, the cells don't respond and the pancreas may not produce enough insulin. So the current drugs that are used to treat type 2 diabetes are either to sensitize cells to insulin or to stimulate insulin release from the pancreas. They don't actually target the inflammation that we're now accepting as part of the disease. For the past 10 years, my group at UCD has studied various mechanisms that control the inflammatory response. And our group has identified key molecules that the body actually produces to promote the resolution of inflammation. These are molecules that essentially signal to various cells to say, calm down, crisis over, resolve inflammation. So what we propose in our work is an alternative way of treating type 2 diabetes, might be to try and resolve the inflammation that seems to be so important in this disease. So to do this, we're testing the various molecules that we found to promote the resolution of inflammation, and early days, but so far so good. We see that these potential drugs can reverse inflammation and insulin resistance in fat cells in a Petri dish, and most recently in obese mice. We've also found that inflammation plays a very important role in driving organ damage in diabetic kidney disease in both type 1 and type 2 diabetes. And we've been testing these experimental drugs in this context too. Again, we see beneficial effects of the test molecules in diabetic animals and in very informative studies on isolated kidney cells that give us a lot of clues as to what may be going wrong in diabetic kidney disease. So how are we going to actually accelerate translation of our discoveries into drugs that may be of benefit? Well, to do this, we're working closely with chemists who make synthetic versions of the molecules that we've discovered, with clinicians and with collaborators in the pharmaceutical industry. So what of the big picture future for diabetes research? Well, I think undoubtedly personalised medicine is going to have a huge impact on the management of diabetes. Devices such as mobile phones can be used as remote sensors of different parameters that are important, such as blood glucose, blood pressure, even exercise activity, and other indices like changes in blood vessels in the eye, detected with an iPhone, of course. These data will generate sophisticated personal health profiles, which should be of great benefit to patients and also reduce the staggering healthcare costs that I mentioned earlier by better management of the disease. We can also anticipate that in aggregate, the resulting big data that will come from all of these personalised sensors will facilitate the development of virtual patients, which will further help us understand diabetes and can be interrogated in drug development, target identification, and trying to understand biomarkers of disease. So this connected health approach describes a multidisciplinary strategy which we're developing at UCD in collaboration with our clinical partners and IT experts. Thank you.